Hello, ladies and gentlemen. Our first and most difficult topic in this cycle is acute abdomen syndrome. This topic is very big. It will be divided into two parts, into two practical classes. First of all, acute abdomen syndrome, this is not a diagnosis. This is such a syndrome that is presented in many different diseases. It is a sudden severe abdominal pain. In many cases, it is a medical emergency. Now look, how many diseases are here? Physician disease, gynecological disease, and of course surgical diseases. We will study only surgical diseases that are accompanied with acute abdomen syndrome. Look how many diseases are here. Different parts of abdomen, epigastric, right, left, gastro. This slide, this is big differential diagnosis of acute abdomen syndrome. First disease and the most simple, the simplest disease is acute appendicitis. It is an acute inflammation of the vermiform appendix. This is a common gastrointestinal disease that affects till 57 per 100,000 individuals each year. We do not know etiology very good and risk factors too. Because of that, this is such a spontaneous disease with a great incidence. What is the pathogenesis? Acute appendicitis comes when it comes obstruction by something, obstruction of appendix. What is appendix? Some remembrance from histology and anatomy. Appendix, like most of the serous organs in abdomen that we will learn further, have these layers: mucous, muscularis mucous, submucous, muscularis propria, and serous. What is important here? At mucous layer, there is lymphatic system, pale lymphoid tissue. It is protective factors against microorganisms. Normally, appendix, this is a part of immune system where many bacteria come and they go out from the one exit. Entrance and exit are only one. If it is obstructed by something, by lymphoid hyperplasia, by fecality, foreign body, worms, or something another, if appendiceal lumen is obstructed, it leads to distension, bacterial overgrowth, and then ischemia and inflammation with damage of mucus and coming to muscularis mucosa, submucous, and other layers. First of all, there are many classifications. We will study international and Russian classification. You will need to answer Russian classification at the exam. All acute appendicitis in Russian classification is divided into complicated and non-complicated. Non-complicated is divided into cateral. This is only mucus. Only mucus is in the process. It is also called simple or superficial because superficial layer for bacteria in the lumen is mucus. Legmonas, the whole wall of appendix is in process. Serous, submucous, but the process is only in appendix, legmonas. Empyema. Empyema, this is such a process when there is pus in cavity. If there are too many bacteria that produce endotoxin and exotoxins and form pus, there can be empyema. And gangrenous. Gangrenous, this is necrosis of the whole wall. This is non-complicated. Complicated by perforation, by infiltrate. Infiltrate can be detected preoperatively and intraoperatively. And intraoperatively, it is very important in this classification. It can be loose or dense. It is very important for surgical tactic. Periappendicular abscess and peritonitis. And this is international so-called American classification by Gomez. It is just the same with Russian classification, but with grades. And these grades, from these grades, American count how much will cost this disease to the patient. You should remember, Russian classification, all Russian classifications are pathogenetical, and American classifications They are financial. Non-complicated, grade 0, normal, grade 1, inflamed. Inflamed means for Russian classification, simple and phlegmonous. Complicated, grade 2, necrosis, gangrenous, peritonitis, segmental or brace, abscess, and grade 4, perforated. Laparoscopic findings. Grades of laparoscopic findings. They are very simple. More grade, more complications and severity. This is grade 0. Normal, like appendix. How to understand? Is it normal or not? It should be the same color as cecum. Same color here. There are different cameras and you should always make orientation for the color of cecum. Grade 1. Superficial appendix, phlegmonous appendix. Do you see? It is rigid, hyperemia and edema. Grade 2A, segmental necrosis in appendix. Do you see? Grade 3, abscess, that is drainage. Do you see pus that comes from the abscess? And grade 4, peritonitis with the fibrin. It is very good seen. It is white. Fibrin comes in the stage of inflammation. Inflammation has acute stage, exudative, and proliferative stage. In proliferative stage, firstly, what comes is fibrin. Signs and symptoms. It is usually dull pain near the navel of the upper abdomen that becomes sharp, but there are different symptoms. Usually the first sign is the symptom of coher. Firstly in the upper abdomen, and only then pain comes to the right iliac area. But pain can be in the lower right abdomen firstly before symptom of coher. And symptom of coher, this is not positive symptom for our patients. It's typical symptoms of all infectious disease like fever, loss of appetite. General logic, remember how to answer. If you answer symptoms and signs about acute surgical disease, firstly pain, specific pain where, and only then local specific symptoms pain, only then symptoms of general symptoms of all infectious disease. Plus to these symptoms, painful urination and difficulty passing urine can be if there is urine in the reactive inflammative process, and constipation or diarrhea with gas. For surgical diseases, specific is firstly pain and only then other symptoms like diarrhea, constipation. For infectious diseases, firstly diarrhea, then it can be pain. Clinics is very variable. Why? Because appendix is very mobile. Pain will be in the place where is inflamed appendix. But look, how many positions are here? This is typical position. Pre-ileal, post-ileal positions. There can be subsacral position, but here, pelvic position. If there will be pelvic position, there will be pain in hypogastrum and not in the right iliac area. If it will be retrocecal, it will be pain not in the right iliac area, but in the projection of urine and in the projection of kidneys. Differential diagnosis can be very difficult in atypical positions of appendicitis. You should know it. Appendix have different positions. One examination, firstly, you make you should understand significant changes in vital signs. In palpation, you should understand where is pain elicited. You should look at the symptoms of psoas sign, iliopsoas muscle. Is it pain there or not? There are many symptoms of appendix. Remember just the most common symptoms like McBurney sign, abdominal tenderness, Rovzin sign, compressing of the lower quadrant gives pain. Why? Pain gives nerves, Appendix itself doesn't have nerves, but mesentery of appendix has nerves. All nerves come from mesentery of appendix with vessels. So if you compress mesentery from the left side, it gives pain in the right side. If it is perforation, if it is abscess, you can palpate palpable mass with fluctuation. Appendicitis, this is mostly clinical diagnosis that you should make on clinical examination. In instrumental diagnostics, only labor analysis with leukocytosis, like with infectious disease, like with all infectious disease, and if there are complications of appendicitis, you can make ultrasound and maybe computed tomography scan. But acute appendicitis, this is emergent situation. You should make diagnosis very, very fast. Because of that, only ultrasound as screening method is made to understand is there infiltrate or not, or abscess. Is there abscess or not? Computer tomography is made only in difficult situations when you do not understand to diagnosis. For example, you do not understand that this is acute appendicitis. You have many variants and you need to understand accurate diagnosis. Look, here abscess in ultrasound, it is uterus. Do you see black water pass? Here appendix, lumen of appendix, just in ultrasound. Computed tomography, normal like appendix. And here you can see abscess, appendicular abscess. Treatment: if patient has pain, pain management. Infectious disease, antibiotics, of course. Surgery: appendectomy. What appendectomy? Laparoscopical or laparotomical? If it is laparoscopical appendectomy, this is a gold standard. It is made for patient because results are better. But if there is such a situation when you cannot make laparoscopical appendectomy, for example, there is big abscess, there is difficulties in the operation, you should make laparotomical appendectomy through limited right lower quadrant incision. This is typical laparoscopic appendectomy. This is appendix with mesoappendix. Here you should make mesentery, you should coagulate mesentery not to become bleeding. You coagulate mesentery, you look totally where is appendix, where it ends, where it begins, and then you make clipation. Typical laparoscopic appendectomy. Next disease, pancreatitis. First of all, a bit remembrance from anatomy. What is pancreas? Pancreas, this is gland, very soft, that is not protected by cereals. Because of that, it can be lightly damaged by everything that comes to the organism. Pancreas has two functions, exocrine and endocrine. Most part of tissue, the biggest part of pancreatic tissue, makes exocrine functions. It produces different ferments to intestine, and Langerhans glands, the very low part, isolates of Langerhans so-called, they produce hormones, insulin and glucagon. Acute pancreatitis, this is a sudden inflammation of the pancreas. There are different etiology, but the most important in different countries can vary. Why? Because acute pancreatitis, this is not only a medical problem, this is also a social problem. The classification that I will give to you, this is Russian classification, Russian dividing of etiology, but in your countries it can be different. In Russian Federation, the most common reasons are two. This is gallstone pancreatitis and alcohol pancreatitis. Because of many problems with alcohol pancreatitis is the most common in Russian Federation. The distinctive trait of Russian drinking culture, this is a high overall level of alcohol consumption and heavy episodic drinking pattern. the big dose of alcohol comes to organs and makes acute damage of pancreas. Because of that, in Russian Federation, the statistic is very big because of alcohol pancreatitis. In the world, a bit another statistic. There are countries, for example, where the leading reason is gallstones, and this statistic accompanies with cholelithiasis. So, most common etiology, biliary pancreatitis and alcohol pancreatitis, but there are also many other reasons that can damage pancreas, including drugs, different drugs, including penetrating ulcers and different traumas, carcinomas, radiotherapy, autoimmune pancreatitis, ERCP, post-ERCP contrast pancreatitis, metabolic disorders, different metabolic disorders, and idiopathic. Idiopathic, at least 25 cases, we do not know the reason. Why it is important? You should understand that every drug, every poison can give acute pancreatitis because pancreas is very soft and not protected. And here see, in Russian classification, less common, less than 5% cases. For example, scorpion venom. In Russian Federation, this is a very rare etiology. But, for example, in your country, this can be often etiology. And for us, this is exotic scorpions. Pregnancy, fat necrosis, Chinese liver fluke, specific for China. You should understand, etiological classification by incidence is different in different countries. Classification is very simple. Acute pancreatitis is divided into mild, moderately severe, and severe. Mild, absence of organ failure and local complications. Moderately, something, local complications and or transient organ failure. And severe, persistent organ failure. Russian classification, pathogenetical. Pancreatitis can be interstitial, sterile, pancreonecrosis, and infected. Pancreonecrosis, this is local complication. This is destruction of tissue. Why this classification is pathogenetical? This classification gives pathogenesis of pancreatitis. Firstly, this is only parenchymal inflammation reactive. Then it comes destruction because of inflammation, destruction of pancreatic cells, and then it comes infection plus to this, and sterile pancreonecrosis comes into infected pancreonecrosis. Histologically, it can be acute hemorrhagic pancreatic necrosis and acute lipatic pancreatic necrosis, and mixed. Why it is important? Pancreas has very good blood supply from very big arteries. Because of that, in surgery, we always are afraid of bleeding, and if their vessel comes into inflammation, it will be acute hemorrhagic pancreatic necrosis. It is very dangerous by bleedings. How comes acute pancreatitis? Firstly, it can be direct damage or it can be obstruction of Wirsung duct. If it is obstruction of Wirsung duct, there will be abnormal activation of digestive enzymes that will destroy pancreas itself. And digestive enzymes, they can destroy fast every cell in our organism, especially active form of trypsin that leads to activation of digestive enzymes, and it comes inflammation, edema, vascular injury, and cellular death. This is main pathogenesis of pancreatitis. Signs and symptoms. Pancreas is innervated from solar plexus. Because of that, pain, first symptom. This will be pain from solar plexus, severe epigastric pain that radiates to the back in 50% of cases. Nausea, vomiting, loss of appetite, fuel, like with all infectious disease, plus it can be hemodynamic instability and other symptoms of organ failure. Why? Because if digestive enzymes come to the systemic blood flow, they can damage everything. And first, what they damage is kidneys, then lungs. Because of that, it can be also respiratory distress, peritonitis, tachycardia, symptoms of organ failure. Specific symptoms. There are also many specific symptoms. You should remember what? You should remember symptoms that are associated with, firstly, severe disease like Great Turner's sign, hemorrhagic discoloration of the flanks. You should remember Mayer-Robson sign. Major-Robson sign has two variants, Major-Robson point and Major-Robson sign. Major-Robson point, this is point of border of inner two-third that represent the B section of left abdominal quadrant. Why it is important? Where comes pancreatitis, at the head or at the body? Major-Robson sign, pain while pressing at the top angle of lateral to erector spine muscle. Very important sign. Remember at least that. Complications. There are local complications and systemic complications. Systemic complications can be by all organs that we have in our organs: renal, circulatory, respiratory, metabolic, gastrointestinal, neurologic, and local complications can be jaundice, pancreanecrosis with abscesses. How to answer this? One more time, remember. All systems of organism can have complications because of pancreatitis. In physical examination, you should find, does he has pain and where? Tenderness by palpation, guarding, peritoneal irritation. This is also a clinical diagnosis, but to understand it, you should accurately, you should make ultrasound. Biochemically, there are no signs that can 100% say this is appendicitis. No, you should make only ultrasound, and in ultrasound enlarging of pancreas by edema, by inflammation, only that can give you accurate diagnosis. Yellow bone, important information for you. Amylase is widely available. Sorry for this technical failure. So amylase is widely available and provides acceptable accuracy, but lipase is preferred for diagnosis of acute pancreatitis. Ultrasound. This is normal pancreas, head, body, tail. Small head, body, and contours of tail. And here, big, enlarged edema pancreas in all of these photos. Computed tomography, normal pancreas with margins, with borders, with small head, and totally destroyed pancreanecrosis here, dermatosis, inflamed, and you see enlarged head here. And here it comes abscess, pancreanecrosis with abscess. Treatment. Conservative treatment, infusion therapy, aggressive hydration with compensation of hemodynamic instabilities by lactate ring isolation, plus antibiotics, infectious disease. Plus, if there is jaundice, if pancreatitis is accompanied with jaundice, you should make biliary decompression. What is general logic in treatment of acute pancreatitis? You should make conservative treatment with specific anti-fermental therapy, but most treatment is symptomatic. Pathogenic treatment and only one good anti-ferment preparat that has good recommendations and that is investigated in clinical investigations that it has effect is actretid, somatostatin. If there is jaundice, you make biliary decompression. Retrograde, like here, from duodenal, or antegrade. When do we need to do surgery? We treat by surgery only complications of acute pancreatitis. If there is necrosis, pancreanecrosis, we should make sequesterectomy. If it is infected necrosis, mini invasive methods for necrosequesterectomy and drainage. All methods should be minimally invasive, because if you do big operation, if you will do in acute phase some big operations, you will become bleeding. It is very, very dangerous. It is the most dangerous complication of pancreatitis. Because of this, only in stable patients you can make endoscopic drainage, minimally invasive, only in stable patients, and necrosequesterectomy. Mini-invasively, it can be also made endoscopically through endoscopical transluminal necrosequestrectomy. Firstly, it comes drainage here in the lumen, and you come to pancreas. And look what we have in pancreas: necrosis, black necrosis. You make necrosequestrectomy there. This is the scheme for you, how it comes: drainage, endoscopic transluminal drainage, and then you make necrosectomy. Next disease, cholelithiasis, gallstones. What is gallstone? This is stone that is formed within the gallbladder out of bile components. There are three big types of stones: cholesterol stones, pigment stones, and mixed stones. Cholesterol stones, they are white and they are very, very solid. Pigment are small and they have color of bile pigments, black, brown. They are more soft and mixed. It is important why, if there is big solid stone, it can give serious surgical diseases. Main diseases that are caused by gallstones are acute and chronic cholecystitis, cholelithiasis, cholangitis, and pancreatitis, biliary pancreatitis. Incidence. We do not know accurate incidence. Why? Because to 20% of patients, they are asymptomatic and they will not come to doctor. They come to doctor only when these gallstones become symptomatic, and it can be till 20 years come from the moment when they come to diagnosis. Etiology. Firstly, we will begin with acute cholecystitis. So etiology, primary, general logic. Cholecystitis, acute inflammation of gallbladder, is divided into calculus and acalculus. From this group, calculus, this is 90–95%. Acalculus is associated with biliary stasis, severe trauma, sepsis. It can be primary gangrenous cholecystitis because of thrombosis of cystic artery, prolonged fasting, and other diseases. Pathophysiological classification of cholecystitis: acute calculus and calculus. Here, simple table for you. By etiology is divided calculus, and specifical, parasitic. By pathogenesis, obstructive, enzymatic, and vascular. Vascular means because of thrombosis, primary gangrenous. By clinical morphological form, just like appendicitis, caterophlegmonous, gangrenous, and perforated, and non-complicated, complicated, plus obstructive and destructive. This is pathogenetical forms. Now classification by stages. This is international classification. It is just like the Russian classification, but with stages. Stage 1, edematosis. This is everything. This is simple, like here, catero and phlegmonous in this stage 1. Stage 2, necrotizing. It comes by days. Firstly, 2–4 days, it will be edema, and it will be interstitial fluid. Then it will be necrosis, edematous areas with hemorrhage and necrosis. And if in 7–10 days you will not have patient, it will come stage 3, suppurative. Different complications of acute cholecystitis. So stage 1, caterophlegmonous, stage 2, gangrenous, and complicated, stage 3. Stage 4, chronic cholecystitis, and in Russian classification it is simply divided into acute and chronic. Complications. What complications has acute cholecystitis? First of all, of course, perforation, necrosis of wall, peritonitis. Like with appendicitis, the logic is just the same. Pericholecystitic abscesses and fistulas. With appendicitis, there can be also fistula between skin, for example, and between appendix. It is called so-called intestine fistulas. Especially difficult are duodenal gallbladder fistulas formation due to erosion of the wall of duodenum by large stone. Large stone compresses not only wall of gallbladder but also wall of duodenum. American classification: light course grade 1, moderate grade 2, anamnesis more than 3 days, as we talked to you, and complicated. Everything is very simple. Clinical examination. You should remember, like previously, firstly pain and symptoms of pain. Where you should remember Murphy's sign and right upper quadrant pain. Very good. Palpable gallbladder, palpable inflamed gallbladder, Musi sign. Read it and remember just these symptoms. And how to understand that this is acute cholecystitis. Most patients, they have an anamnesis of gallstones like biliary colics radiating pain, fat intolerance, food intolerance, tenderness of upper abdomen. You should always ask about it. Complications of gallstones. Acute cholecystitis can be also complicated by specific complications specific for gallstones. It means pancreatitis, cholangiolithiasis, and obstructive cholangitis. And one of the most dangerous with obstructive cholangitis always comes jaundice, mechanical jaundice. Diagnosis. First screening method and high specific method is ultrasonography. Gallbladder, much of water, it will be very good seen. To understand accurate position of the stone, you will not always see it in ultrasonography. You can also use magnetic resonance cholangial-pancreatography or CT, computed tomography. But ultrasonography, this is a method that can accept diagnosis 100%. Then only for operation for accurate position you can make MRA or CT, computed tomography. Less good is endoscopic retrograde cholangio-pancreatography if you do not have magnetic resonance cholangio-pancreatography. Diagnostics. What will you see on ultrasound? You will see gallstones firstly, then thickening of the wall more than 3 millimeters. This is specific sign of inflammation of acute cholecystitis. Increasing of longitudinal and transverse size. From these symptoms, remember the thickening of the wall more than 3 millimeters. This is very important. Look here, gallbladder with intraluminal flap, and here gallstones and pericholecystic fluid. MRI, many gallstones that also come where? To the cystic duct, and then they will come to choledoch. And here, paravesicular abscess on tomography. Computed tomography and MRI are also widely used to diagnose complications of acute cholecystitis. What treatment will you do? Here I gave you a very simple slide with scheme. How to understand what to do with gallstones. If it is not symptomatic, you can ask the patient, has he indications for surgical treatment? Does he want surgical treatment or not? If yes, laparoscopic cholecystectomy. If he has symptoms, has he complications or not? If he has no complications, you can make operation. Or if he has mild symptoms, you can try to treat him conservatively, but only if it is catarrhal cholecystitis or chronic cholecystitis. If it is phlegonous cholecystitis, only operation, only laparoscopic cholecystectomy. If he has complications, what complications? Treat these complications. Laparoscopic cholecystectomy in acute cholecystitis within 3. Here it is written better now by recommendations. 24 hours it should be make emergent operation. Pancreatitis, treatment of pancreatitis. Cholangiolithiasis. If patient has gallstones and choledoch, you should make ERCP and get them out of there. Choledocholdite extraction, it is also called. Exceptions to expectant treatment. This is very important slide. What should you remember? Firstly, there is also such a disease that needs differential diagnosis with acute cholecystitis. It is also called gallbladder cancer. If there is high risk of gallbladder cancer, and where it comes, calcification of the gallbladder, large gallstones, that make constant damage of gallstone, you should always make histology. Laparoscopic cholecystectomy, always you make histology. Why? If it is gallbladder cancer, it should be totally another operation. It should be also resection of the fourth segment of liver. It is very important. From this slide, you should remember about gallbladder cancer. Treatment: infectious disease, antibiotic therapy. If you cannot make laparoscopic cholecystectomy, for example, patient is very old, patient has very big risk, you should always make drainage of gallbladder. The best is percutaneous gallbladder damage in patients with sepsis or very old or with high risks, poor surgical candidates. And if it is mild acute cholecystitis, you should make laparoscopic cholecystectomy first line. If it is moderate severe and you cannot make laparoscopic cholecystectomy, maybe you should do laparotomic cholecystectomy. Severe acute cholecystitis often is operated by percutaneous gallbladder drainage, or if you come to operation and you cannot make laparoscopic cholecystectomy, you should do opened laparotomic cholecystectomy. This is typical laparoscopic cholecystectomy, pores and laparotomic cholecystectomy. Laparoscopic cholecystectomy, this is gallbladder, cystic artery. You make firstly clipation of cystic artery, then clipation of cystic duct, and then you remove it. Here it is very important to understand all structures. Read about hepatopancreatic biliary trigonum. It is very important. It is also called trigonum of Callos. Surgery, when he makes operation, always should find trigonum of Callos. You may have such a question in the exam. Trigonum of Callos, this is trigonum where there is haledach, cystic artery, and cystic duct. Treatment, one more time, percutaneous drainage. Here there are stones, gallbladder, drainage. Mechanical jaundice, this is last topic today, and this is common complication of pancreatitis and cholelithiasis. First of all, there is classification of jaundices: pre-hepatic or hemolytic, hepatic, hepatocellular, and post-hepatic or cholestatic or mechanical jaundice. Hemolytic, this is often in children. Hepatocellular, this is physician disease. Typically, this is cirrhosis. This is not surgical disease. And we will study post-hepatic mechanical jaundice. This is surgical disease. Classification is the jaundice is divided by classes: class C, class B, class A. Here it is word class, you understand. Mistake. Mechanical jaundice by the severity is divided into these classes. Why? This is international and Russian classification, because postoperative mortality from treatment and complication, they strongly are connected with total serum bilirubin, strongly. Etiology. There are many diseases that can cause mechanical jaundice, from malformations, congenital diseases, and benign diseases like strictures and stenosis to inflammatory disease. You should always say it at the exam by the groups: benign, malformations, inflammatory diseases that we study today, tumors, different malignancies, all hepatopancreatic biliary organs, all of their malignancies can cause mechanical jaundice as parasitic disease, group of parasitic diseases. Differentiation of jaundice. From this table, you can see classical differentiation of jaundice, but you should remember all of these symptoms cannot accurately make differential diagnosis of jaundice type. Why? Because stool color, a holy color, it comes while bilirubin will not come to duodenum. And why does it not come? Mechanical obstruction. But if mechanical obstruction is not total, stool color can be not alcoholic. Urine color, this is intoxication of bilirubin by the body. If there is not big intoxication, urine color can be normal. Do you understand? Because of that, The only method to understand that it is mechanical jaundice is ultrasound. Only dilated biliary ducts in ultrasound can say, yes, this is mechanical jaundice and not another jaundice. Signs and symptoms. You should remember, mechanical jaundice has itself complications, cholangitis and sepsis. Charcot-striate, this is symptoms of cholangitis. You should remember it very good. Pain, jaundice, fever. Renal spin test, this is Charcot-striate cholangitis plus septic shock and mental confusion. Renal spin test, this is symptoms of septic shock. Physical examination, you should look at these symptoms plus skin color and eye color. Plus to this, you should look at the symptoms of diseases that cause mechanical jaundice. On ultrasound standard investigation, you can see dilated extrahepatic bile ducts. This is accurate method to understand that mechanical jaundice is mechanical. The jaundice is mechanical. But if you need to understand better reason, you can also make cholangio-pancreatography and MRCP to understand the reason of mechanical jaundice, to make differential diagnosis by etiology. Look here, very, very big, dilated bile duct. MRI, also big, dilated bile ducts. ERCP, percutaneous transhepatic cholangiography. Why are they all made? To understand reason of the block. Gallstones, malignancies. Do you understand? If it is malignancy, you should make biopsy. Because of that, it is very important. Ultrasound, this is a screening method to understand that jaundice is mechanical, but to understand the etiology of the reason, you should make another investigations. Here you can see endoscopic retrograde cholangio-pancreatography, stones, 2 stones here. Percutaneous transhepatic cholangiography, exchanged bile ducts, and here block. Such a block is often because of malignancies. Contrast and change computed tomography to see if there are masses, malignant masses that can be etiology of mechanical jaundice. And here you can see malignancy, cancer of pancreas. If you have malignancy, you should make biopsy. Malignancy, this is always histological diagnosis. You make core needle biopsy. Here it is malignant tumor in the head of pancreas, and you should make biopsy. This is core needle biopsy under the guidance of endoscopic ultrasound. This is gold standard now for diagnostics of malignant tumors of hepatopancreatibiliary zone. Treatment: mechanical jaundice, biliary decompression. If it is cholangitis, resuscitation plus antibacterial therapy. If it is cholelithiasis, the reason of mechanical jaundice, then you should make lead extraction. Benign biliary structure, balloon dilatation. Management strongly is connected with etiology. Because of that, you should make correct diagnosis. If it is pancreatic cancer, you should make full TNM staging, and if you can, you should make WIPO procedure, pancreatic duodenectomy in resectable case, and unresectable palliative treatment with biliary stenting and chemotherapy. If it is helicarcinoma, also full staging, and then you should understand, can you make surgery or not? Choledocholecysts, different types of choledocholecysts. You should simply know that choledocholecysts, this is benign disease, congenital disease with different types. You should make hepatouniostomy with resection of these sites. Biliary decompression, different variants, integrate percutaneous transhepatic cholangial outer drainage with stenting here, or retrograde by endoscopic transpapillary biliary drainage. Here, you make retrograde stent, endoscopic biliary restention, and you restore passage of gall. Thanks for your attention. Goodbye.